Welcome to our live stream from Deuk Spine Institute. I'm Dr. Deuk Majin. Our patient is here with back pain, chronic back pain. He's had it for years. His back pain is coming from multiple different places. As most patients' back pain comes from multiple places, his pain is coming from multiple places. The average patient with chronic back pain has 4 specific diagnoses causing the pain. In his case, he has 14. Shot? Is that it there? I'm getting dizzy. All right. So we have 3 discs that are causing back pain. Number 3, 4, 4, 5, and 5, 1. And we're going to start by treating the discs. Shot. All right, so we're heading towards the 3, 4. I could probably start just a little bit lower. The first thing I'm going to do is get to the disc through the use of a needle. Needles allow surgeons to sort of guide a trajectory or path to a target. In this case, the target is his disc, specifically the L3-4 disc on the right. Everyone agree? L3-4 on the right? And then we have the L4-5 on the right. Shot. So far, things are looking good. We're nice and lined up. Jordan has done a phenomenal job with the machine. I can actually feel the herniation. Next knife. We're going to make a 7mm incision. The entire back surgery will be done through a couple of incisions that are very small. These incisions are measured in millimeters rather than inches. And the reason we're able to do millimeter incisions is, well, it's because we're doing it minimally invasive. We're using what's called an endoscope, which is a tool that allows surgeons to see inside the body with very small incisions. Shot. Almost there. Shot. How's he doing? Good? Just about there. I can feel bone spurs. Shot. He's got a lot of bone spurs. AP. Needle. And shot. Good, good. Lateral. It's way too. Wait, no, it's way too. And we're not in the right place. Come on, don't do that. I'll tell you when I need your help. Please fix that. I'm trying to move things along. Shot. All right, so far, on one side we're doing pretty good. On the other side, we need a little more work. Shot. All right. There we go. Trying to get into the disc here. 4, 5. Uh-huh. All right. On the other side, he's got some scoliosis. It's actually shifted his spine this side up. Shot. I'm hitting the iliac crest. There we go. Shot. That's looking much better. Heading to 5, 1. Shot. Probably a little bit too medial, possibly. Shot. That's looking better. Give me an AP view, please. I'm going to use an X-ray machine, front, back, side-to-side views, to guide the surgery. I need you to, yeah, that's better. All right, back to a lateral view. You can see that the L3-4, L4-5 needles, the L4-5 is just hitting the bottom of that L4 bone. I'm going to have to wiggle it a little. That's it. That worked. We're in at 4-5 now. Just got to work on 5-1. Any questions, Henry? Shot?
At this moment, no current questions.
All right, Jordan, line me up at 5-1. Feel free to ask questions, Shot. We do take questions during the surgery. L5-S1 is the most difficult disc to get to, endoscopic transforaminal style. Shot. The reason is the iliac crest, but also in this patient's case, lots and lots of arthritis affecting that facet, making it really challenging. But I think we might have it. Shot. How's he doing, doctor?
Doing very well.
Are we almost ready to wake him up?
How are you doing, my friend?
Oh, he's awake. AP. You're doing great. We're going to put you to sleep in a minute, but I need your help first. All right. We're using two views, AP and lateral, on the x-ray machine. Oh, that's perfect. And we're going to have you asleep in a minute, but I need your help, okay? You're doing great, by the way.
Doing great.
Everything's going as good as it could possibly go for you right now. Henry, let's show the audience in just a moment. Not yet. But let's show the audience, Sean. Don't talk too much. We can't have a full-on conversation with you. We just need your help, okay? We'll have a conversation after surgery. Are you having any pain right now?
Right where you at.
All right, good. That's what we expect. Relax. You're doing great, Sean.
Deep breath in for me.
Mm-hmm.
There you go. You got it.
You're doing great.
Get him breathing.
Huh?
Get him breathing.
Good, good. Well, he's pretty collapsed here, and I'm going to have to do this when he's asleep. So that's as good as I'm going to get it. Are you comfortable? Are you having any pain? How bad is that on a scale of 1 to 10? How high did that go? What's the highest it went?
Give us a number.
How high does it go?
10? 9, 10.
10. All right, there we go. We're just testing your disc. Good job. Is that where you get your pain? All right. How bad is that on a scale of 1 to 10? 10?
9.5.
10. We just do 10. All right. So you got, I can't test the third one, but two that I tested are 10 out of 10, and they're your typical pain. You get to go to sleep. When you wake up, we'll be done. So, folks, we just tested 2 out of the 3 discs. I can't test the third one. It's untestable at this point. But the 2 that I tested are, that I thought were causing his back pain, they are. And he has 10 out of 10 pain. So he's going to go to sleep now, and we're going to start his surgery. Okay? Count from 1 to 100 for me out loud. Shot. Count from 1 to 100 out loud. Shot.
Nice and slow.
You're doing great. Hold this down. You're doing great. Shot. Look at that. Shot. All right. Yeah, it's good. You're doing awesome. Keep counting. When you wake up, the surgery will be over and that pain will be gone permanently. So he has degenerative disc disease. Nope. He has really collapsed discs, full of arthritis, and very painful. And what we're going to do, even though the disc is collapsed, we're going to go in there and we're going to take care of the pain. And there's a reason why we can do that. Henry, let's show our audience our video on why do discs cause pain. Shot. Well, the video you just saw explains why a injured disc in the spine can cause so much pain. Turns out that 85% of chronic back pain is due to injured discs. And we are now going to go in and repair that disc using a special laser and an endoscope. What we're going to do is we're going to clean out the tear in the back of the disc. It looks like our irrigation is sluggy. All right. Now, even though the disc is totally degenerated, we can still repair it to the point that we can get rid of the pain. And that's our goal. We want to get rid of his back pain. I think the irrigation is sluggish. Please check all the connections, huh?
Can you check the lines? Check the line, please. Yep.
It's very sluggish. Is it clipped here? No? Davis, you want to help them?
Not in here. Over there. Has to be back there. On the Y, whatever the Y connection is. Check.
All right. Let's see the grabber. Any questions from our audience?
Yes, we have a couple of questions. This first one coming from Ping on Facebook,
Hello, Ping. Welcome back.
asking, Morning Doc, is it possible to get a normal nerve conduction study test after the surgery when previously it's been abnormal?
Yes, it is possible. It's not on our end. It is 100% on your end. Look at this shit.
Yeah, has to be coming from there. You see over here? Wait, one second. That could be it. You see? That's it. Pull, you pull. Go down. Pull. Let's see.
There we go.
Got it. Okay. Got it.
It was not on our end or your end. It's the middle. God. All right. Laser.
Thank you.
The nice thing is that most of the stuff is common sense.
It's like we have a problem with the IV in the last case. Same thing.
So basically, folks, when you have nerve damage and the nerve test picks up on it, that nerve damage is from several different possible causes. One of them is chemical damage to the nerve. We call that neuropathy. Neuropathy will not get better with this surgery. Neuropathy does not get better with surgery. It gets better with nothing, unfortunately. Neuropathy is permanent. Then there's radiculopathy, which is compression of the nerve, and that's what we can fix. And you will see improvement over time with the radiculopathy if the surgery is done early enough, the surgery is done properly, the nerve is decompressed. You will see an improvement in radiculopathy. Okay? On the other hand, if the nerve damage is permanent, you will not see an improvement in radiculopathy. So it's a great question you're asking. There's no easy answer. The truth is, it depends on the kind of nerve damage, it depends on how good the surgeon is, and how good the surgery is, and it depends on how soon the surgery is done before you have too much damage. That's like saying if a house is on fire, can you save it? Well, it depends on when you get there how much damage is already done, and it depends on how bad the fire is, and it depends on your equipment you have to use to put the fire out. So you can't just ask a general question like that and expect the same answer for everybody. It depends on a lot of factors. The most important is what surgery you have and who does it, and also what kind of nerve damage there is. All right? So if you see the word neuropathy, sensory motor neuropathy on your nerve test, that is not fixable with any surgery in the world. There is no surgery that can fix sensory motor neuropathy. Okay? But there's surgery that can fix pinched nerves. This is that surgery. This is the best. Next question.
Next question coming from Lori on Facebook,
Hello, Lori. Welcome.
asking, when watching a lot of your live procedures, I hear you say that you remove 50% of the herniated disc. What happens to the remaining herniated disc material left? I've been told over and over, just let it heal on its own. The disc will reabsorb on its own. Is this true? Also,
yeah.
when you laser the disc material, does that affect the spine being stable or the disc height?
Yeah, great questions, Lori. So first of all, when I talk about getting rid of 50% of the herniated disc, what I'm saying is you need to get rid of 50% to get rid of the symptoms. But you have to get rid of the right 50%. We're not just taking any 50%. This is not a cherry pie where you can cut it in half and take half of it. It's the same on both halves. This is, we have to remove the right 50% of the disc. That's the part of the disc that's stuck inside the tear. Once you remove the herniation stuck in the tear will heal. The symptoms go away. Patient's symptoms go away. Back pain goes away, leg pain goes away, as long as you remove the right 50%. Now, the other 50% is the 50% that's not doing anything to cause symptoms. And that's usually the part that's in the epidural space. Okay, we're removing the part in the lateral recess and the part in the neural foramen, but we leave the part in the epidural space because number one, we can't reach it, but more important than that, it doesn't cause symptoms. It just stays there and it gets scarred in and doesn't do anything. Second question was about removing disc and laser and instability, I think, correct? The laser does not cause instability. The laser actually is a treatment for instability. Instability is defined as severe pain, back pain, neck pain, or neurological compromise with normal physiological movements and loads. Basically, it means you have horrible back pain or leg pain, weakness, numbness, tingling with normal activities like walking around, bending, lifting, doing stuff. And the laser surgery fixes that. Therefore, the laser surgery that we do, Deuk laser disc repair, is a stabilizing surgery. Did I answer the question, Henry?
I believe so, yeah. The last being also the laser disc material, does that affect the spine being stable or the disc height?
Yeah, the disc height is already collapsed. We're not going to make it collapse more. So we're not affecting the disc height. Now, if you do what's called a discectomy, then you will affect the disc height. You'll lose the disc height. It'll collapse. So we don't do a discectomy. You don't want a discectomy. That's what other surgeons will do. They will do discectomy. Avoid discectomy. Next question.
At this moment, no current questions.
Let's share with our audience what it is that we're actually doing here with the laser. Almost.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Okay, you see how the Deuk laser disc repair surgery that we're doing actually helps get rid of back pain by eliminating the source of inflammation. Remember, folks, it's inflammation that causes pain. Get rid of the source of inflammation, you get rid of the inflammation. All right, do we have my song or not? Are you able to search? Tell me when you're ready. And you can crank it up. I don't want to get booted from YouTube or whatever. It's called, no, it's Rondine, R-O-N-D-I-N-E, El Nido. I think it's A-L-N-I-D-O. 2 words, El Nido. You see it? It's by Pavarotti. Luciano Pavarotti. I think this is the best song. A little louder.
I like the clapping before it starts.
That's from the last song. A little louder. Yeah, this is it. You found it. Louder, louder, louder. Oh yeah, beautiful. It's the most powerful song, operatic song I've ever heard. Everyone likes Nessun Dorma, but this is better. No, we've had it for years. Perdona l'amore. I wish I had that voice. Listen to that. Listen to that. Incredible. All right, we're moving on to disc number 2. Non torni più. Turn it up just a little bit. This is so powerful. All right. Shot. See, even the audience can recognize that quality. All right, Henry, any questions from our audience?
At this moment, no current questions. Oh, never mind. I take that back. We have a question from Ping on Facebook once more,
All right, we'll take it.
asking, how long does it take typically for radiculopathy to become irreversible, or is it different from patient to patient?
Yeah, great question. Radiculopathy, so for those of you who don't know what radiculopathy is, it's basically nerve damage, and it's nerve damage affecting a peripheral nerve versus a spinal cord. We call spinal cord damage myelopathy, peripheral nerve damage radiculopathy, and it's a compressive type of damage where the nerve is being squeezed, as opposed to a chemical damage, which we call neuropathy. And what really matters is for radiculopathy, you can turn it down just a little bit. What matters is that when the nerve is being damaged, that it's damaged a shorter period of time and it's damaged for as minimal as possible. The shorter the time period of compression or squeezing, and the less squeezing, the faster the nerve will heal. So when you talk about patient characteristics with respect to healing from radiculopathy, the most important is nothing to do with like nutrition or any of that stuff. It's all about how hard was the nerve pinched and how long was it pinched for. And so is there a specific amount of time? No, I can't tell you. That's all I treat is, I treat so much radiculopathy, it's like what I do every day. So I'm definitely a world expert on it, but even a world's expert cannot tell you how much or how long results in irreversible damage. What I can tell you is this is very important, what I'm about to say. Lots and lots of neurosurgeons treat radiculopathy. They treat it surgically. But lots and lots of neurosurgeons do not do the surgery properly. And when the patient comes out of surgery, they still have the symptoms of radiculopathy. And the surgeon always tells the patient the same thing, which is give it time. Now, if you do the surgery right, give it time will help because it'll heal. But the problem is most of these surgeons don't do the surgery the right way, and the nerve is not not unpinched. Okay, it's not unpinched after surgery, so it's still being pinched. So why would surgeons leave the nerve pinched? The answer is it's their training. It's the way they do the surgery, the type of surgery they do. So there's a surgery called microdiscectomy. There's a surgery called laminectomy, microdiscectomy. These are the most common spine surgeries done in the world. Microdiscectomy, laminectomy, discectomy, they're all the same thing basically. You're removing the bone called the lamina, part of the facet joint usually, and the ligaments in between. And it's a very destructive surgery. The problem is that when you, as a surgeon, when you get down there to the nerve, number one, if you don't have a new fiber. If you don't have a microscope, let me have the grabber. If you don't have a microscope to do the surgery, microscopes are like $250,000 piece of equipment, and most surgeons don't have a microscope. So they have to use what are called loupes, which is little magnifying glasses that they put on. And those magnifying glasses, you just can't see very well down there at the bottom of that hole. So they end up making the hole bigger, which means they take more patient's bone and ligament out to make the hole bigger. That's why this surgery done endoscopically is so valuable. Go ahead, you got time. Because doing it endoscopically, the surgeon doesn't have to take any bone or ligament out if you go transforaminal, which is what I do. The problem is most surgeons don't know how to do the surgery, and they're not able to do the surgery because they've never been trained to do it. It's extremely rare you'll find a surgeon that knows how to do this. I went to the best neurosurgery training program in the United States, and we did not learn how to do endoscopic transforaminal surgery. I had to learn from a student of the guy who invented it, the surgeon that invented it, Dr. Parvis Kambin. And it's a very niche group that I was very lucky to be trained by them. They were in a training mood, they felt like training another surgeon, me, and a few others. So I got really lucky that I was trained by them, because of the whatever 10,000 neurosurgeons and orthopedic surgeons in the United States. Only about 5 of us know how to do this surgery endoscopically. Very, very few. The rest have never been trained and never will be trained. So, to answer your question, you have to do the surgery the right way, and that means you have to operate in the right spot. Well, the type of surgery all these surgeons have been trained to do, the microdiscectomy, it's impossible to get to the right spot where the nerve is being pinched. Because most nerve pinching that causes radiculopathy happens in the lower back. It happens in the lateral recess and the neuroforamen. And a microdiscectomy cannot treat that. It only treats central and paracentral herniations. It cannot treat a foraminal or lateral recess stenosis, which is what causes radiculopathy. So patients are doomed if they don't choose the right surgeon and the right surgery, basically. And 95% of the surgeons out there won't do the right surgery. So if you have radiculopathy, you go to one of the 95%, 9.5 out of 10 surgeons out there, you're going to get the wrong surgery, because that's the surgery they know how to do and that they want to do, because that surgery will result in you getting more surgery and more treatment, and that's what they want. They want you to be in treatment the rest of your life, okay? I'll give you an example right now. I have this lawyer who's working on a case for me, and he charges me, $10,000 a month, okay? Does he want the case to go away and be resolved? No. He wants to keep charging me $10,000 a month as long as I'm willing to keep paying him. And so it's like these parasites of society don't want to fix problems. They just want to keep them going so they can keep taking money from you. Look at Apple, for example. Apple iPhone, right? They charge you for the phone a lot of money, and then they change the charger and put a different charger. So now everybody has the old charger. It doesn't work anymore on the new iPhone. You got to buy the new one. And then they change the apps. They change the software. They're always looking for ways to charge you more and more and more. At Deuk Spine, we figured out a way to fix people and fix their problem permanently. Now, some people will re-injure themselves and they have to come back and get a second surgery, but that's 1%. That's 1 in 100. The rest of the patients, whatever we're fixing, it fix it permanently the rest of their life. Okay? I grew up in a time when refrigerators, you buy a refrigerator, your parents have a refrigerator when you're a baby, and you grow up with that same refrigerator your whole life. And then you leave and you go have your own refrigerator at your own house. The refrigerator was built to last a lifetime. Now you buy things and they're built to break down after a few years. Why? Because the companies that sell them want them to break down, because that means more business. You have to buy a new refrigerator. So the point is, the treatments that are available to people with radiculopathy in the United States and the rest of the world are bad treatments. Treatments that don't work, and they're treatments that lead to more treatment. And the additional treatments aren't much better. They don't really help either, like epidural steroid injection or fusion or whatever. They recommend pills. The point is, they're making money on you even though they're not actually fixing your problem. And they'll tell you right up front, this probably won't work, but it's worth a try, and it's the only thing we've got. At that point, you should leave and you should come literally and get this procedure done, the Deuk laser disc repair. This is the best. We can treat foraminal stenosis, we can treat lateral recess stenosis, we can treat paracentral disc herniations. There's nothing we can't treat with this surgery, whereas the surgeries you're being offered, discectomy, can't treat the most common causes of radiculopathy. That's why you don't want that treatment. That's why I don't do that treatment. It's not that I don't know how to do those treatments. I know how to do them. I've been trained on them. I'm very good at doing them. But they don't work. They don't work. That's why I don't recommend them. All right.
We have another question.
Sure.
This comes from John on YouTube. John,
Hey, John.
John asks, why doesn't Medicare cover this procedure?
That's a great question, John. The reason is Medicare doesn't want to cover anything. If you are a Medicare beneficiary, you've noticed over the last years that Medicare keeps cutting their benefits. Whatever it is, home health, physical therapy, occupational therapy. Medicare is starting to require prior authorization for cervical fusion. Medicare is run by the commercial insurance companies, Cigna, Aetna, United Healthcare. Luis, hold this here, please. They don't want to pay for surgery because the more surgery they pay for, the less profit they make. Your Medicare is run by maybe Blue Cross. If you have Blue Cross Blue Shield Medicare, it's a Medicare Advantage plan. It means that Blue Cross is given $1,000 a month for you, and they've got to cover all your expenses with $1,000 a month. Now, they'll get 1 million patients, so they get 1,000 times 1 million every month. And they've got to cover those 1 million patients' health bills. So what they've learned to do is just to deny everything. Don't approve any treatments. Don't pay for any bills that the doctors send or hospitals send. Try to get out of paying. And that's why a lot of hospitals are not taking Medicare Advantage anymore, because their insurance companies, it's not Medicare Advantage, it's Medicare Take Advantage. You understand what I'm saying? So the Blue Cross will go to Medicare and say, give us $1,000 a month for 1 million patients that we'll cover. All right? Then the government gives them that $1 billion or whatever it is they get, $100 million. And then when you go to get medical care, they say, oh, we're not paying for that. That way they get to keep that $1,000. I mean, you guys really, why do I have to explain this to you? You guys should already know this stuff. And they're hiding it from you. They don't talk about it, but go look it up. Look up Medicare Advantage plans and hospitals. Just Google it and you'll see. Now, the reason you don't know about it is they keep it out of the news. The insurance companies are making so much profit off of you Medicare patients, they don't want anybody knowing about their game. But it was actually in the news recently when the congressmen were saying how bad Medicare Advantage plans are and how they're taking advantage of the hospitals and the doctors by not paying them. So that's the problem, is when you don't get your surgery paid for by Medicare, somebody is keeping that money and making a profit. Somebody is profiting off of you not getting your surgery or treatment paid for. And by the way, it's not just this procedure, it's every procedure. Okay? Medicare will deny prostate surgery. They deny proton beam therapy. They'll deny everything they can because it's not really Medicare, it's the commercial insurance companies running Medicare. If you look at the United States map of Medicare, you'll see that there's something called a MAC, M-A-C, Medicare Administrating Company. And for example, in Florida, Medicare is run by Blue Cross Blue Shield. So Blue Cross Blue Shield gets paid by Medicare to manage your benefits. What that means is managing your benefits means deny your care, deny treatment, deny payment. So Blue Cross gets money for denying your treatment, denying payments, denying authorization, okay? It's a scam. And, you know, it's not me that needs to fix it, it's you guys that need to fix it. This is your problem, you created it, you fix it. I'm just making you aware of it because the other doctors don't know much about it. They're too stupid to figure it out. They just keep getting their reimbursement cut every year. Yeah, I said that because it's true. Been saying it for the last 15 years. We've been broadcasting these surgeries for 10 years now. And I've been announcing these things about insurances for 10 years. Go back and watch these surgeries 10 years ago, and you'll see what I'm talking about. The problem with Medicare is your problem. You guys have to fix it. You got to go and fight Medicare, fight Blue Cross, fight Cigna, take them to court, sue them, talk to your politicians. The reality is, folks, is that the insurance companies deny your treatments because they're allowed to deny the treatment, okay? And what allows them to deny treatment is, unfortunately, the state. The state of Florida, for example. Is he asleep? So the state insurance agency, the state laws about insurance allow the insurance companies to deny your treatments. In my opinion, what we should do is, if an insurance company doesn't want to pay for surgery, they deny it. They should have a board, a panel that's made up of civilians. And that panel gets to decide if the surgery should be covered or not the insurance company. If a doctor or a hospital recommend a treatment or test and the insurance company doesn't want to pay for it, a panel should decide. And that panel should be independent, and it should be comprised of citizens, civilians, who hear the evidence on both sides and decide if the treatment should be covered. Not the damn insurance company. They have way too much power, and they're abusing their power by not paying for your treatment. By the way, the non-payment of treatment, it's not just spine surgery, it's everything. I mean, you're going to see more and more denials. Right now, there are millions of denials every day in the United States. Millions of denials. And back in the 80s or 70s, there were almost no denials. Right, Davis?
I'm thinking about when I started practice, I never knew what a peer-to-peer was.
There was no such thing as peer-to-peer. Back in the 90s, yeah. Every single thing we want to do is peer-to-peer.
And they're not our peers. They're pediatricians.
But then it's not that they're not our peers that we're talking to. It's that they're paid by the insurance company to say no.
That's right.
And if they say yes to the treatment, they're going to be fired. They won't be hired again. So they're incentivized to say no. Yeah, it's a lie. There's no such thing as peer-to-peer. They already know what they're going to say. And I've had these peer-to-peers, okay? But yeah, when I started, there was no such thing as peer-to-peer. They have this peer-to-peer so they can say they did a peer-to-peer, but they're going to deny it anyway. As soon as you get on the phone with a peer-to-peer phone call, you got to schedule it, first of all. They don't pay you for it, so you got to take your time and spend an hour of your time doing a peer-to-peer for free. I mean, is that fair to ask doctors to work for free? No. Right? I mean, they pay us so little already, $80 for a visit. Now they want us to spend the time preparing for a peer-to-peer, do a peer-to-peer, get paid nothing. So basically they're punishing us for recommending treatment to our patients.
It's easier just to walk away from it than spend all that time trying to get it approved.
Yeah, a lot of doctors won't do the peer-to-peer. They just won't do it. All right, give me a second. Let me see if we're there. Let me just see. I think we're there. Let's try it. All right, so we're having a hard time getting into 5-1, but we're going to give it a go. Shot? Yep. But it's tight. It's real tight. Any other questions, Henry?
Yes, we got a couple questions. This next one coming from Lanu on YouTube,
Okay.
asking, can aging weaken the annular tear?
A little more. Can aging weaken the annular tear? I don't know what that means, aging. Like, I guess what he's saying is, I get an annular tear, I get older, does that weaken the tear more?
That's what I was thinking, yeah.
I mean, I don't think aging weakens it, but more time weakens it. The longer you have the annular tear, the more inflammation, the more scar tissue, and the more scar tissue, the weaker it gets. So, I don't know if that answers your question. I hope it does. Thank you. I got it. Very, very tight.
This next one is a comment coming from John once more on YouTube on the follow-up of their Medicare question, saying, I have traditional Medicare. However, I was told by your representative that your laser surgery is considered experimental. I believe a fusion would be covered.
Yeah, that's correct. So, first of all, traditional Medicare, John, if you're in Florida, it's run by Blue Cross Blue Shield. They have a name, though. They're called First Coast Services. Maybe you've heard of them. I don't know where you live, but whatever state you live in, the United States has been carved up by these hyenas, and if you got to figure out what the name of your MAC is, but in Florida and Puerto Rico and the Virgin Islands, it is First Coast Services. First Coast Services is a subsidiary of Blue Cross Blue Shield. And the government of the United States pays them for every dollar they save not paying for your treatment. So what do you think they're going to do? They're going, if they have one way to not pay, and it is to call that treatment experimental, what do you think they're going to do? They're going to call everything they can experimental. And then they're going to call everything they can't experimental. They don't care, because the only way for you to overturn their experimental decision is to sue them. And you can't beat the United States government because they got it on lockdown. So there's your problem. It's a corrupt system. You now are aware. Figure out what you want to do. What was the second part of his comment? Oh, fusion would be covered.
Exactly,
I don't
yeah.
know that fusion would be covered. I wouldn't say fusion would be covered. Medicare has been tightening down on fusion. We got 5 minutes left on the DLDR. 5 minutes left on the DLDR. Then we're going to switch to the piriformis and SI. So I don't know that Medicare will cover a fusion. You know, that's hearsay. You've got to meet the criteria. They have specific criteria, and you may not meet that criteria. What I think my rep was saying is that Medicare does cover fusions. That would be a alternative for your problem, but Medicare may not cover your fusion. And guess what? Push this a little closer. Here's the caveat. Let's say I do a fusion on you tomorrow, and I spend $100,000. That's what it costs me to do your fusion. I pay for you, all right? Make an investment. Here, I'll help this patient get his fusion. We bill Medicare. Medicare says we're not paying because it's experimental, unnecessary. Guess what? I'm out $100,000. You have a great back. You're happy. Life goes on. And frankly, most patients just don't even give a shit that we didn't get paid. But that's literally $100,000 out of my pocket. Because where we do these surgeries, I have to pay for your surgery before I get paid. So if Medicare decides not to pay, which they do all the time, by the way, at least 50% of the time, they'll say patient didn't need the surgery. They won't pay. And you have no way to beat them and win. Basically, you're out $100,000. And been there, done that. Not doing it anymore. Okay? So, folks, you guys have what's called socialized healthcare. You just don't know it. The insurance companies have socialized it. They are restricting it. They are, what do you call it? You know, socialized healthcare is a central agency that decides what you should and shouldn't get, and they pay the bills or don't pay the bills. That's what we have. The central agency are the private health insurance companies. Okay? Hate to be the bearer of bad news, but you know what? That's why we do these broadcasts, so that you guys can learn the truth about what's happening. I'm sorry. The truth sucks so bad. It's miserable. And you guys pay into Medicare your whole life. As long as you're working, you're paying taxes called FICA and FUCA taxes, FICA, FUCA. They take about 0.5%, maybe 1% of your paycheck, and they say, oh, it's for Medicare so you can have medical benefits. And then you get to be Medicare age, and guess what? Oh, that's not necessary. Oh, you don't need that. Oh, we're not paying for that because it's experimental. All they got to do is say that, and you have no recourse. You're screwed. So you want to fix the problem, make the politicians run on, he's moving a little bit, make them run on, I'm almost done, about 30 seconds. Make them run on a platform of health insurance, okay? Health insurance. You want good health insurance. You want insurance that can't say no to doctors who are trying to fix you. That's how you fix the problem. Next question.
Next question coming from Ping once more on Facebook, saying, I'm looking at coming for treatment at the end of the year. What date does the office usually close for Christmas?
I don't know, Ping. That's a great question. Typically, we're closed between Christmas and New Year's. So I would say if you come on the 23rd to the 1st, that's a bad time to come. You'll be doing your own surgery. If you come before that week or after, then we can help you and do your surgery. The best thing to do is your MRI review. And once you do the MRI review, you will know exactly what you need done. I know that we've communicated by, I think, either YouTube or Facebook Messenger, I think, and you were saying you have 2 discs that need to be done. So the best thing to do is a free MRI review. Henry, you want to put that link in there?
Copy that or
Get
read
a
it?
grabber. I got about 1 minute left on this disc. Then we're going to end this broadcast and go to the Piriformis SI. Dr. B, just 1 minute and I'll be done. Oh, that's a pretty good herniation.
We do have another question.
Well, if you want to stop, we can stop and bring them back and do the rest later. Berndes, your call. You tell me. I don't mind bringing them back. Laser. I can have the rest done in 10 minutes. All right, let's do this. All right, I'm going to wrap this up. We're going to take questions later. We're pretty much done, so we're going to end the stream.
Copy that.
Lights on.